number 30. Hey, if you watch our student webinars too, we're side by side. We're on 30. We just did 30 for the student webinar the other day. So that's kind of cool, huh? We've been doing this for a while. Now, we do things a little different with the club webinar versus the student webinar. Both of them are covering topics that you've sent us that you have questions over. And we had a great one come in day before yesterday, I think it was, and it was regarding coding polyps. And I thought to myself, hey, there's a lot of people that struggle with this, trying to find the right code, the ICD code, but I'm going to throw in some CPT codes, some things you need to be aware of with polyps as well. First of all, this is the question that came in from one of our students, and it was fabulous. So let's just go over this quickly. They had stated that they hadn't been able to figure it out, you know, and again, maybe this was just a unique situation when they were looking at the textbook and the workbook, and it stated that the diagnosis indicates it as a polyp and includes the location it is in, because that's what the documentation will always do, by the way. So they went to the index, and they it said to use a D code, which would be a neoplasm code, but said there's a K code as well, which are more specific to polyp. So the student is doing everything right. They're looking in the index and they're seeing all the options, and it's a red flag for them. Hey, we got some D codes here. We got K codes. So, you know, what's up? And then it said that even though the index will only point to the parent code K, if you don't try to look up a more specific location under polyp. So what do I do with this? What am I supposed to do? Is it going to be a D code under neoplasm with a, then go to the neoplasm or the tabular and look at polyp, or are you going to go to the K code and then go to the tabular and look at the polyp? So again, this was a great question, and this is something that can be very confusing when you first start out. So the main thing you need to know is we can have hold on. Oh, I might sneeze now. Nothing like getting choked on breathing. Let me see if I'm going to sneeze. If I get choked, you guys can code that. Okay. So the first thing we need to know is that we can have polyps all over our body, right? That's the number one thing. I'm going to get me out of hard candy just in case my asthma kicks up because I got choked. So forgive me for putting a hard candy and talking at the same time. I usually don't have to put it in there for very long. Common polyps, though, are going to be in the digestive tract, in the intestines, the colon, the anus. It goes all the way up like to the cecum. So it's really important that you understand the anatomy of not just the digestive tract, but all over, because we can have polyps in the sinus cavities, and there's other places that you can have a polyp. Excuse me again. Okay, I think we're okay now. I don't think I'll start wheezing. That was another lecture, right? Asthma. So ultimately, what is a polyp? Now that we've determined that we can have one anywhere in our body, more or less, it's just abnormal growth. Now, when I say that, what else is something that is associated to abnormal growth of cells? Neoplasms, right? Doesn't matter if it's benign or malignant, it's abnormal growth. Well, a polyp is abnormal growth, but that doesn't always mean that it's considered a something that would be a neoplasm. Okay, so the most common place that people get polyps, though, is in the colon and the rectum, on that inner lining. And they're all different shapes, they're all different sizes, and they have terms for the different types of shapes. And we'll go over those a little bit. So a colorectal polyp, which is kind of, I think, what was being addressed in that question when we looked into some more. So the student says, well, what is it? Is it a neoplasm or is it a K-code? And so the key is to go look and see what type of a polyp it is. So you're not just coding for a polyp, you're going to have more verbiage to look at that's going to direct you to the proper place to go. So we are always trying to get to the higher specificity. The more you increase your knowledge base, understanding the disease process, understanding the terminology, location, and anatomy, it's going to make you have the ability to get to the to a higher specificity, and it's going to make you code faster, because you're not going to have to think through this. You're going to think, oh, okay, this makes sense. One thing that I noticed that was really interesting here is it said most often they grow on the left side of the colon and in the rectum. Isn't that interesting? I wonder why when these polyps tend to go on the left side. That would be an interesting study to see if we could figure out why. But again, they can be in other places. The two main types of these colon polyps, and again, that's what we're focusing on. We're going to look at other types maybe at another date, or this should launch you into looking at other polyps, right? Increase your knowledge base. The first one is going to be hyperplastic colon polyps. So what are these? They have little to no malignant potential. Okay, these are very common, right? Little bulbs of tissue that grow abnormally, and they are not neoplastic in nature. They are considered serrated polyps, and they're typically found in the distal colon and rectum. Now, your verbiage, what does distal mean? Farther away from the middle. Okay, so that means it's going to be, you're not going to see them at the beginning of the colon, but the farthest end and towards the rectum is the most common place to see hyperplastic colon polyps. And the other type is let's see, I've got to say that with the right accent in the place, adenomatosis. That's probably a better way to say it. So that is colons that polyps in the colon that have a much higher chance of being malignant. Okay, now they can be benign. They can go in, they can snare them, take them, do the testing, and look at it, and they say, yeah, this is benign. But this particular type, if not removed, can turn into cancerous. Okay, benign and then go into malignant. If you have this type, then they want you to come in more often to be checked, have colonoscopies to make sure that if another one starts up, that we don't have that situation again where it turns from benign to malignant. Okay, now these tend to be tubular, tubulovillous, and sessile serrated are the terms that you'll see, the verbiage that you'll see in the documentation. These, again, they will go in, they'll do the biopsy, or they'll remove them completely, and so they're excising them and then checking them, and the cells themselves under the microscope look different. I've got a great slide. The smaller they are when they find this type, the better it is. The bigger they are, more tendency to be malignant. So you'll notice that they'll measure these. So here is a picture. Now, everything that I've looked up for this particular lecture is all in the resources. And I even kept one site up because it was so fabulous, and linked that in the club when we talked about, when the student and I talked about it, because it was a great resource. It was off of a HEMA person. So if a polyp is flat or sessile, then again, that's what we're looking at. The polyp is just kind of like a little cabbage growing there. But if it's on a stalk, it looks like a morel mushroom, right? Okay, and you'll see stalk mentioned in the verbiage. You can go in and look all day at Google images of different type of polyps, both nasal polyps and colon polyps. Now, these polyps, these colorectal polyps, can actually grow in any part of the colon. But I said it was kind of interesting that one document I found said, hey, it likes to grow on the left side, though. They tend to find that more often. So that's pretty interesting. How do they know that? Because of the statistics they've collected from us coders. Isn't that great? Also, it says that a majority of polyps that are taken out are not cancer, okay? But there are some that are precancerous, and we already talked about what type that was. The way you reduce the risk for colorectal cancer is getting those polyps removed right away. Now, here is some other verbiage that you're going to see in the documentation that I wanted you to be aware of. So we said tubular, we said villous, and we said sessile and serrated. Now here is a graphic for what a slide, what the pathologist would be looking at from a tubular to a villous. Now, what comes to mind when I think of villi, I think of little fingers, right? We have villi all over our body in different parts. But if you look at that, see how that is a little more fingery looking, where that tubular is kind of compact? You know, if you like pathology, and I used to really like pathology, like back in high school when I first went, graduated and stuff, that was something that fascinated me. I thought I might go into that, but ultimately for me, it got to be a little too boring. It just wasn't exciting enough. I was into blood and guts. So this is a little harder to see. I've got it marked in the resources, so you can go out and Google image this. This was off of a slide share. And this one just says giant polyp, okay? And this is a flat polyp over here, okay? Pedunculated polyp, you can see, look, it has this stalk involved. So this is that polyp that I was talking about, that I was stumbling on how to say it, adenominous, or it's not how you say it, but you know what I'm trying to say. That's this particular type. So go ahead and do some more research on those. And then here is the area where we're talking about those polyps being able to be found. Here is also an image of what these polyps look like to the pathologist, how he identifies them. Okay. And again, the resource for that is out there. Take some time to look at them. It's pretty obvious, right? The different types that you're going to see. Here is from a great website that was a case study on hot and cold snares and removing them. So there is a polyp right there. Now, what would you identify that polyp as, right? It's not a tubular, pedunculated, or nothing like that. That is like we said, that sessile, that flat polyp. Okay, and it's really actually pretty small too, right? So what they do is you look at A, so they've identified the polyp, and that white tube that you see, that is the device that has the snare on it. So the snare is the little wire, okay? They put that over the polyp, and then there is more than one way to do it. They can do a cold cautery and freeze it, or they can do a hot where they burn it off. And they literally just, that wire heats up or freezes, and then they pull that back. Notice there is a different polyp in E, and then after it's removed in that F, that last picture. So D is a 8 millimeter polyp removed with a hot snare, and then E is resection site after the hot snare polyectomy in F. Oh, I'm sorry. D is the cold snare, and then E is them getting ready to do a hot one, and then F is the hot. Because the letter here identifying the image is after the description instead. So I got a little confused. So there you go. Interesting, right? Here's another technique that I wanted you to be aware of. This is a much larger, it's 40 millimeter lateral granular type colon polyp. Okay, this is so the other one was 8 millimeters. This one's 40, much bigger. And so the treatment's a little bit different. They're going to do an APC because they don't want a recurrence of the polyp. And then on top of that, they are doing a clip closure of mucosal defect after resection. Okay, so let me kind of unpack that for you. What they've got is this giant polyp that they have to remove, and they have to get down enough to be able to remove any of the tissue so that it doesn't grow back. And in doing that, they've weakened the mucosa, that lining. You have thickness to that part of the intestinal tract of the colon, but we've really thinned that out by taking so much of this polyp. So they're going to put these clip closures on there to make sure that that defect doesn't become a bulb or like an aneurysm type thing is what I'm thinking of. So again, this is a little bit different. Now, we don't know what type of a polyp this is, except for that it's a granular type. That's texture. And then it would be interesting to have seen the path report on that. Because it's so large, I think that they're probably going to indicate that this is cancerous. But look in the image B there. Okay, so you got A here where it shows it. And then in B, look right there. I think we might have some further polyp tissue down there. Now, I don't know for sure, this isn't my expertise and everything, but doesn't this look a little bit of like the tissue that's there? The inside of the intestines, the small intestines and the large intestines are different on the inside, but really it's pretty smooth. Okay, we don't see a lot of texture there. So anyway, I thought that was pretty fascinating. It's important to know with the documentation when you're reading that to see what the provider's thinking is that most of these colorectal polyps don't have any signs and symptoms. Now, if they're in the large intestine, more often they do. So it's really important that they do the screenings for cancer because there could be things that are happening in the stools that the person isn't really noticing. And by the time they notice something, then it's already a problem, right? The things that they're looking for would be blood in the stools, of course, would indicate we got a problem. Excess mucus, because the body is trying to compensate for an irritation. A change in bowel habits, like being constipated or frequency. And abdominal pain, abdominal discomfort is going to be an indication. And remember, the large intestines goes up high in the abdomen, because we saw how the anatomy. So we can have discomfort and pain up high. We can have it on the left side and the right side, and then we can have it down low as well. So that's noteworthy. Understanding who is at higher risk for having problems with polyps and polyps that can turn into, or that are precancerous, would be if you're overweight or obese. If you're overweight and obese, you just end up having problems with everything. That they always make that an indicator. If you're over the age of 50, So you guys know I turned 50 this last year, and last time I went to the doctor, they said, "Oh, by the way, you're 50 now." And I said, "Yeah," thinking, okay, what do they want me to do? But you're at that age where they want to go in and do a colorectal exam. So it's time for me to have my not colostomy. I don't want a colostomy. It's time to go be scoped, I guess, because 50 years of age and older is when they want to start checking you. I'm going to go put that little candy back in my mouth. All right. If you're a smoker, now you think, why does that have to do with colorectal cancer? Because you're breathing it, right? You're breathing the smoke. But the fact is when you use tobacco, it tends to be a vasoconstrictor. And that could maybe be one of the reasons. But you've got carcinogens in your body, and then they like to go other places in the body. If you've ever had colon polyps or colon cancer in the past, that makes you more likely to have problems. So my daughter, who has IBS, when she got scoped and they found one little polyp, and they weren't concerned about it. But the fact is, she was 17. So, oh, we found a polyp. That's, not necessarily good, but don't worry about it, blah, 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 because it was fine. Definitely glad that they went ahead and removed it, right? If you have IBS, she does, ulcerative colitis or Crohn's disease, because that's like a constant irritation to the digestive tract. If you have type 2 diabetes and it isn't well controlled, don't get well controlled confused with a person being compliant with a diabetic regimen. It's not the same. Being well controlled means that you're able to keep your sugar stabilized with whatever treatment that you're getting. If your diet and exercise and that's fine, then you're good. But let's say you're even on insulin and they can't seem to manage your sugars and they're just up and down, up and down. You're compliant, but your body is just not reacting well. Okay, that would be diabetes that's not well controlled. Okay. I know a lot of people get that confused because they think, oh, that means you're hiding Twinkies under your bed, your pillow, right? No, that's not that doesn't mean that's not being compliant. Well controlled is your body's reaction. More information that would make you more susceptible would be things like genetic changes. If you had FAP, which is familial let me start over. Adenomatous, yes, polyposis. Then again, that makes you at higher risk. Gardner syndrome, Lynch syndrome. If you've got MAP, which is MYH associated polyposis, let's see, it's Piet's. Let's see, I think that's Jaeger syndrome. That's not one I'm very, very familiar with. And serrated polyposis syndrome, which you've already seen some of those terms that we've talked about. So those are conditions that make you more susceptible to having polyps that are cancerous. Now let's look at some CPT codes to be aware of, because for the most part, we're talking about ICD because that's the question that came up. But I just wanted to throw something out at you because CPT is part of what we do and we want to kind of paint the whole picture. If you go look up in your index on the CPT manual under polyp, this is what you're going to get, a list. And so you think, oh, okay, well, where is polyps of the colon and rectal? They're not there because that's not what you want to look up. So again, you think, oh, well, this says anal, right? Doesn't that? No, this is a sinus type because it's not just anal, it's CHOANAL. That's not the right code. So I wanted to give you that. Look, if you're going to have a polypectomy, they only give you the choice in the index of the nose or the uterus. Remember, I told you you could have polyps all over your body, all over your body. And did you realize you could have polyps in your esophagus? Yes. So you're not going to look up polyps. Instead, you're going to go look up where is the polyp. So if you go to anal, all right, and you will get a drop down of abscess or endoscopy. So we're going to do an endoscopic procedure of that body part, and then it gives you a list of all of these codes. So here is, let's see, here is a aneoscopy ablation of a lesion, right? Now, all this book view and everything, that is, I should have taken those out because that is just an icon, okay? But this is where you're going to start looking at removal of lesion cautery, right? Polyp, other, via snare. Okay, so again, you're doing an aneoscopy because that is, and if you're doing rectal, you look up rectal, or you can look up colon. Okay, and you're going to get these a list of the codes. Okay, I want to give you that heads up because I know that's frustrating. Now, a great site that I found, and let me just pull this over real quick so you can see the source, and I did link it in there for you. So just real quick, I want to show you this website. This is where I posted in our, I posted it in the CCO Club, so it's already posted and linked if you go and look at this question in the club. But this particular person, Kim Carrier, I think is how you say her last name. This was done on 3/6/2018. They updated it, but I pulled out a lot of information from this. So this is Health Information Associates, great resource that you should look at. And again, it's important for us to show you how you go up and do the research when you're not sure. And I've kind of broken this down, kind of put some of the stuff on the slide to make it a little bit easier to see versus being able to see it here. So let me just get rid of that now. And what the question that she was answering there, Kim was answering, is how do we code history of colon or rectal polyps without further clarification of the type of polyp? Okay, and hyperplastic or I can't say that, adenomatous. I'm just going to quit saying it. And she used a coding clinic, which is great. And they're saying, hey, it would be Z86.010 history of this type of colon polyp would be assigned if you had the documentation by the provider of a history of colon polyps. This is the code right here that you would use. Now, she goes on to say that the coding clinic tells you also that if you have a personal history of other diseases of the digestive system, like a rectal polyp, you're going to use Z87.19. It's an other disease. Okay, and then she went so far as to say here is history personal of neoplasm, because we know that I gave you a heads up that it's either going to be found under neoplasms or it's going to be a K code. So this is history. So is it benign? Could it be in a brain, or could it be a colon polyp? Z86.010. You're going to look under history, personal, neoplasm. All right. Now, colon polyp, is that cancer? No, that's not saying it's cancer, right? They're saying that's how you find a colon polyp, is if it's under neoplasm. Now, she went on to give more information. So I kept grabbing this because I thought this was good information. But that tells you, by looking at that, was that is why you're going to find these polyps in the neoplasm, because they're abnormal growths of tissue. That's a neoplasm. Is it benign or cancerous? We don't know until the pathology report comes back. And by seeing how the history codes are set up, it kind of gives you a window into, oh, what are they thinking, right? If they, again, history of benign neoplasm, it's going to get you to Z86.1, and then the colon is 0, and the rectum is 8, going to end in 8. Now, she said, but how do you code for a current hyperplastic colon polyp? Not a history, a current. Notice it's hyperplastic. That's the key. All right, because this term right here that I can't say, this adenomatous that I say it different every time, and hyperplastic are 2 different types. Okay, so if it's hyperplastic, it's a K code, K63.5. Polyp of the colon is for documented hyperplastic colon polyps, regardless of the site within the colon. Okay, so it's a catch-all. Whereas if it is not, then it's going to be a D code, right? If it's not hyperplastic, it's a D code. That would be a D12 code, and it's telling you it would be D12.0 through 9 because it's documented by site of the colon, right? This is a neoplasm. Hyperplastic is not a neoplasm. Then she goes on to say, if you don't have any further documentation, so what do we do with a colon or rectal polyp without any further documentation to specify what we got? You know, it doesn't say hyperplastic or not. So then it says that yours to code K63.5. This is the default code for colon polyps. Rectal polyps would be K62.3. All right, that's important. That you need to write in your manual. You need to, I would even maybe even make a note of that in my index where you see polyps and in the index and say unspecified colon polyp, you know, then you're going to code that as the K63.5, and then for rectal polyp, K62.1, right? Default. Because you're not indicating that it's this type. Okay, now, excuse me, I went and found an abstract. And so we're going to look at some scenarios. Feel free to ask questions. I'm sorry that I've got this cough. Okay, this is an abstract that I pulled off of a website talking about different techniques for removal of polyps and what works. Sometimes that's the best way to get the documentation that you're looking for, you know, to give you the verbiage that you want to be familiar with. I do that all the time, and I suggest you do that too. Just type in case studies, and then it'll come up that it's an abstract. So the background for this scenario is that we have inflammatory polyps, okay, and that it's a common sequela or late effect in patients with IBD, inflammatory bowel disease, which in fact, IBD is kind of a catch-all for all different types of IBS, okay. Then they say these polyps, they need to be removed or can usually be removed by snare polypectomy. Now, there is limited data as to what technique works best, so that is thus why they did this abstract. So they are saying that they did 2 cases with a hot snare resistant inflammatory polyp. One was with a patient that had Crohn's disease, and the other one was an ileocolonic anastomosis patient. And the other one, as well as having ulcerative colitis, it looks like. So they had the second one had a polyp in the pouch inlet. You can go out and study more about the anatomy of how that worked. So the results showed, and this is kind of what I wanted to get to, is this is the way you're going to see the documentation show up in these procedures. They sedated, it was a sedated endoscopy was performed. Now I'm going to go ahead and read this just because I want you to get the verbiage. So start over. Sedated endoscopy was performed, which showed a large 2.5 centimeter, not millimeter, pedunculated polyp. Now we know what that means at at the ICA in the first patient and a large 5-centimeter pedunculated polyp at the pouch inlet in the second patient. Hot snare polyectomy was initially attempted but failed in both patients, meaning they couldn't get all the tissue. Then an endoscopic needle knife polypectomy was performed, which helped complete the polypectomy. Both procedures took about 25 minutes each, which is a little bit longer than what I'd like to spend. The patient tolerated the procedure well and continued to do well after the procedure. The final pathology diagnosis for both patients were inflammatory polyps with extensive fibrosis. Okay, and fibrosis, just so you know, is this fibrous tissue that has built up. So like scar tissue is the best you can have scar tissue on the inside lining, right? And ultimately, what was done, they did a needle knife assisted polypectomy in hot snare resistant fibrotropic inflammatory polyps. So the conclusion from the abstract was that that this needle knife assisted polypectomy really appeared to be the most effective when you had something that was resistant to the hot snare removal of these inflammatory polyps and getting all of the polyp tissue. So again, this isn't something that I was showing you to code, but I wanted you to see the verbiage. And you can go out and look at these abstracts on this type of technique, okay? Actually, these colostomies are done a lot. So it could be something that you're called to code very often. We are already through our time. I can't believe that we were already through that. Is there any questions for what we talked about already? Any questions out there? If no questions, again, this was a question that did come up in our CCO club. It was a really, really good question from one of our students, and it is a kind of an area that can get very, very confusing. So once you get that little bit of clarification that the club is absolutely fabulous for doing, and you're able to link in other things like that great article that I found that not only explained different types of polyps, but how to even code for the history of polyps, then we can do all of that through the club. Okay, it looks like we had one question. I have a question to ask about integumentary status. What is the meaning of layered closure for single layered extended debridement? Oh, okay. Well, let's see. Actually, I might be able to answer that really quickly. So we're doing a layered closure or single layered with extensive debridement. The thing about this, let's look up closure, and I can tell you where to go. Okay, closure, and that would be, what do we want to close? And we're going to look here, whatever body part, if we're not a skin graft. Let's see, eyelid, distal segment, surgery, repair complex procedure of the integumentary system, intermediate procedures of the integumentary system, and simple. So that's your three launching points. Is it simple, intermediate, or complex? When you are dealing with simple procedures, I think of those as, if you're ever sewed before, that's that whip stitch right over the top. They numb it, they make sure it's cleaned out. You know what, they maybe just irrigate it a little bit, and they just but they actually don't do a running stitch. They do individual stitches, because if you do a running stitch on something that's very, you know, long in length, if one of the stitch pops, then they're all going to come undone. So they'll do one stitch, and they usually stitch in the middle first, you know, kind of the technique that they do, and pull that tissue together, and then they'll go out from there, okay? Or they may go middle, you know, right, left, and then put 2 more, depending on how many stitches that they need to do. If you want to see some simple closures or intermediate closures, I would jump out to Dr. Sandra Lee's. When she removes cysts or lymphomas, lipomas, just fat, then she does that closing of the wound. Now, if you're just removing a simple cyst, but it needs to be closed up, it can't heal from the inside out, then you'll see her just put in a few little stitches there. You know, she's even done those, maybe put a stitch on somebody that had a dilated pore whiner, which is really just a blackhead on steroids, you know. But intermediate is different. Intermediate is when we're getting layered, okay? And what we're talking about is, here's our laceration or our wound, okay? We don't close the top, because if we close the top like that, then what's going to happen in the middle? We're going to get infection, because our body is going to send all of that good fluid and white blood cells to start healing that. We don't want to like scab up in there, you know, and any bacteria or something that's left in. It's now growing with a warm, moist area that has no place to drain. Okay, so they're not going to do that. So what they do is they close here. They put stitches underneath, and they used to call it catgut. It's stitches. The thread is going to be threads that we can leave in the body, and they'll just dissolve. And then they close up the top. Okay, it does not, the determination isn't how big or long the wound, the laceration is, or the repair, it's depth. Okay, now it could be really, really long and have lots of jagged edges as well, where we had to go and debride by cleaning it out, irrigating, and cutting off edges because it's so direct. So we need to have a nice clean edges so that it, you know, it would be like trying to hem a skirt that wasn't a straight line, and you know what I mean? It's just, it's not going to work, right? So again, sometimes they'll do that. That can end up being classified as intermediate because more work's being done. But complex, very detailed about complex. We're going to have layered closure. We're going to have debridement, and the depth could even be down to the bone. Okay, so we're not just putting a couple stitches underneath and then on top. No, we're having to put the tissue back together to form it. There's a lot of thinking and process that goes in this, and probably, I don't know if Dr. Sandra Lee on her website has any complex skin repairs. She might. She's removed some lipomas that were huge and left big gaping holes in people that she really had to do a lot of work with, and cut off tissue because the lipoma was like this. So you can't just sew that back together, or you're going to have this floppy skin, right? It's been stretched out. So she has to cut through all that. And maybe that would be considered, you know, I think if you could find something like that, that would be complex. So back to your question, the definition or the meaning between a layered closure or single layered with debridement, yeah, you can have, it would be classified as an intermediate repair if you're going to do any debriding, okay? Versus a simple repair, very self, it's just usually not debriding, it's cleaning and irrigating. Okay, that's it, and they'll do a lot of irrigation with that type of a wound. So I hope that answers the question. We got another one from Whitney. I would like your thoughts on a scenario. Say a patient had 2 polyps, was undergoing a colonoscopy, and only 1 polyp was able to be removed due to the patient not being able to tolerate the procedure. How would you code this, and wouldn't you need a modifier for reduced services? Okay, that's an excellent question. And just a heads up, when you go and do some of the research that I did, and I didn't add it to this lecture because I thought it might be a little above and beyond what was being asked, but there are times when you can't go in and remove a polyp or multiple polyps in one setting. So they'll stage it and they'll schedule you to come back and do a removal at another time for all kinds of reasons. Okay, maybe one is that they go and remove a polyp and it just bleeds more than what they're wanting. Maybe the person was on Coumadin therapy and they had them off their Coumadin, but the bleeding just was a little more than that provider wanted to do on just a regular outpatient colonoscopy, and says, okay, let's think this through and have another plan to remove the other polyps. Okay, that could be it. Or that there could be polyps in different locations. Okay, when you're coding for polyps, if you have multiple polyps in one area, think of them like skin tags. Okay, if it's one area, let's say it's in the rectum, and then you have another polyp in the cecum, that's two different areas, right? So that's two different codes for the removal of polyps because it's two different body areas anatomy wise. So that's the first thing you have to ask yourself: where are the polyps located? Okay, because there'll be different codes for one in one area, like the anus and the rectum. It would be two different codes: the rectum and the transverse colon. Again, you could have two polyps where, if you're just doing removal of the polyps, when you look at the codes, you'll notice that they'll have more description there. But the second thing you asked was, what happens if they go in and they remove one polyp, but they don't get to remove the others? So they'll probably stage it. But the modifier is not based on not being able to remove the polyps. The modifier is based on how far you go in the pathway. Okay, so if you plan to go to the cecum and you can't get to the cecum because they do a they do a polyp removal and there's bleeding, or for whatever reason, and they can't go ahead and do the rest of the procedure. Okay, so that absolutely would be a removal, or the modifier. They didn't get to do what they planned to do. Okay, and your modifier is based on, was it the surgeon saying, hey, we're stopping, or the anesthesiologist saying, hey, this person's blood pressure has bottomed out, we got to stop? Or is it because they literally can't get farther because of maybe there's a polyp so big that they can't advance any farther than that? Okay, all of that makes a difference on which modifier to use. But ask yourself one thing: why did they stop the procedure? Were the polyps in the same place and they only removed one, but they couldn't remove the others? Or is there a polyp in a further location that they visualized, but they didn't go there for whatever reason? So you got to answer those questions really first before that you can decide. But removing polyps, it's pretty standard to always remove polyps when you see them, whether they're small or any size. But they could choose not to remove a polyp. Okay, because that's not why they went in there. They didn't go in there to remove polyps. They went in there to go look, to do a diagnostic, right? And then if they saw polyps, they're going to take the polyps, and it changes what they do. However, if it's staged and they say, no, we're definitely going in to remove polyps. We know, we visualized last time, there's 3 polyps and we're going in to get them. And then if something stops you, for whatever reason. Okay, so all those scenarios are different pictures. The other question is, can you give an example of when you would use the zoo code, ZOO.00? Well, let's just go bring that up. See, this is why I call it the zoo code. These are encounter codes for going and seeing the doctor. Encounter for adult checkup, not otherwise specified. So there is, the reason you would go to see your doctor is to establish care. All right. So when we moved to Texas and the area we're in, we need to get new PCPs, right? So I need to establish care. And if there's nothing wrong with me, then it would be Z00.00. If there's something that they need to address in my care, okay, then you don't code that code, because this is with no abnormal findings. Now, I have wonky kidneys, which I've told you all about. So I take HCTZ for those codes, or for those kidneys, and then I also have to take potassium for that. So I would never go to a doctor to just establish care where I wouldn't have some type of abnormal finding involved in there. Okay. But if it's just a regular checkup, nothing, you're not refilling medications, that's different. Now, if you are going to be seen for administrative purposes, okay, or pre-procedural, there's codes, or special screenings again. But if you look down here, and I think this says, it breaks it down here for you. I love find a code because of this. So these are the different reasons you would use the Z0 codes. So again, they're I don't have any complaints or suspected or reported diagnoses. I would always. My son would always, that has RA. My other son that has epilepsy. Of course, he's never going to have a zoo code, because wherever he goes, epilepsy is pertinent to his care. Okay, now if you're going to do another exam without complaint, suspected, or then that means it's not a general exam, but it's for another reason. An administrative exam, medical observation, examination for observation for other reasons. Then you got newborns, malignant neoplasms, follow-up exams, screenings, etc. Okay. So that's how you would use those zoo codes. Notice also, whenever you do that, let's pay attention to the other codes that are around there. Okay. Oop, you're seeing my German Shepherd's tail. I'm sorry. This has been a really crazy night, hasn't it, with me choking and gagging and everything. Here is an encounter for general adult medical examination with abnormal findings. So instead of the zoo code, you'd have Z00.01. So that's what I would be, right? They're always going to have an abnormal finding with me because I take maintenance medications. Okay. So I hope that helps you out with that. Other question, Whitney says, would you code screening colonoscopy codes? Well, yeah, there are screenings. So let's go to the tool. Let me just look that up, and then we'll end with this one, because it looks like we're running out of time. Good questions, guys. Let's see. Let's look at screenings. And you know what? Screenings are done in ICD. So, and we'll just do a catch-all of screening. So what are we going to screen for? Here are all the things that we could screen for. Fever, gonorrhea, gout, let's see, diphtheria, disability, intellectual, let's see, HIV screening. So let's go look at colon, the colon. Let's see, did I pass that? I don't know if it's under digestive. What is it under? Disability, disease, colonoscopy screening. There we go. Encounter for screening for malignant neoplasm of colon, because why else would you be doing a screening for a colonoscopy, right? So let's just go open that up and see what it says. It's going to be kind of slow. I apologize. And it says encounter for screening colonoscopy. And then it says, oh, by the way, if you're doing an examination code to signs and symptoms, encounter, just be careful. Let's see, examine related to pregnancy. Of course, that's all going to be different. And then it heads up, screenings. It says, is testing that's performed to determine whether an otherwise healthy individual with no signs and symptoms, key, of the particular illness or disease is being screened, test positive for conditions. If the testing is performed to rule out or confirmed a suspected diagnosis, so the patient has signs and symptoms, this is considered a diagnostic test. Okay, not a screening. So the different screening, I don't have any signs and symptoms. So if I'm going to go because I turned 50 and I need to go have a colonoscopy, it's a screening. I don't have any signs and symptoms except for the fact that, I turned 50. However, if I have those signs and symptoms, any of those signs and symptoms that would make my provider concerned, and we talked about that on that one slide, like blood in the stools, abdominal pain, et cetera, then it ends up being diagnostic. And that's a different code, right? Now, if you have a screening test that results in a positive finding, meaning you're, okay, you've got an asymptomatic patient, but they do a screening and it confirms the diagnosis, okay, then you're going to put that confirmed diagnosis with the screening. All right. All right. I think that was great stuff, guys. If you have any questions, don't forget anytime, put them in the club. Our CCO Club members always get priority with us. We always answer their questions first because we like them more than you. No, I'm just kidding. You send in topic requests. Of course, anytime you want to see a particular subject covered, send it to us. We're here for you to answer your questions. If you're watching us on Facebook or YouTube, don't forget to like and subscribe, share with your friends, and you can put topic requests there, but it's probably going to be delayed. So go out to cco.us and let us know. Give us a heads up of what you want to know about. All right. And we'll be happy to comply. Thanks, guys. Have a great rest of your evening.